Suchitra madam
Good evening, sir. Good evening.
is
I'm
traveling.
always
again.
there in AMOGS.
Raj said he will
We are
join,
live now.
but I can't see him. Yes, I think I'll just give him a ring.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar organized by EMOCS Emergency Obstetrics Committee with Jharkhand Societies. So it's my privilege to introduce the MOCs of today's webinar, Dr. Nivedita Datta ma'am. Ma'am is the past president of Bokaro OBGYN Society, consultant at KM Memorial Hospital and Research Center, Bokaro. I welcome you, ma'am. And it's my privilege to introduce Dr. Monica Umbadan ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalya Nursing Home and Atava Fertility Center. Ma'am is PAC committee chairperson, AMOGS 2022 to 24, website coordinator for AMOGS 18.
That's fine, Saiti, I think.
I welcome you, ma'am, and hand over the session to you.
Thank you, Saiti, for the kind introduction for me and Dr. Nivedita. And thank you, Sneha ma'am, for giving us an opportunity to coordinate this program and convene this. Today is the 60th episode of the Emergency Obstetric Committee webinar, but with Jharkhand societies. So we're very grateful to our chief guests, Dr. Suchitra Madam and Kiran sir, and our guest of honor, Muralidhar sir and Krishnendu sir, for accepting our invitation and being there today. I would like to formally welcome Dr. Sneha Bhayar Madam. Saiti, Sneha ma'am slide, please. First.
Let us go for...
Ma'am, I'll just introduce you and then we go for the inauguration ones. So Sneha madam has a lot of first to her credits to her name. She has been the first national faculty from the Yavatmal Society. She is a winner of this MS Signature Award twice. She has been the past chairperson of the Breast Committee in Foxy, as well as the Medical Disorders Committee at AMOGS. Madam also has been taking lead in various social programs. She's very active even in the IMA Maharashtra state. Ma'am, I would like to invite you and formally welcome all the delegates with a prayer. So let's inaugurate the webinar and then you can formally welcome everyone, ma'am.
Thank you, Monica. Thank you so much for that kind introduction. A very good evening to all of you. My respect and regards to all the seniors here. First of all, I would like to welcome the chief guest for today's program and of course the AMOGS president, our dear friend Dr. Kiran Kurtakoti. Madam Suchitra Pandit, I think she'll be joining soon from Dhaka. And of course, guest of honor, Sir Muralidhar Pai and Dr. Krishnendu Gupta, sir. He's also on his way to Dhaka, so I hope he just joins soon. Of course, all the respected faculties here, all the chairpersons and panelists, and the president and secretaries of all the societies of Jharkhand. I would like to welcome all of you. I would like to also welcome the convener, Dr. Nivedita Datta and Dr. Monica Umbadan, who is the, who are the pillars of this program. In fact, they have been doing all the hard work. And I would like to welcome all the office bearers of AMOGS, especially Dr. Kiran. I have already welcomed Secretary Dr. Bipin Pandit and Treasurer Dr. Madhuri Mendare, and of course, immediate past President of AMOGS, Dr. Rajendra Singh Pardesi. I would like to welcome my dear friend Dr. Parag Biniwale, who is the ICOG Chair and the National Coordinator of AMOGS. And with this, I I would like to go ahead and go for the lamp lighting and invoke the Lord's blessings. Your society, can we have the prayer, please? So, thank you so much. And once again, with God's blessings, we go ahead with our inaugural ceremony. I welcome Dr. Kiran Kurtakoti, the AMOGS president, for his precious words of guidance for this program and, of course, for all of us. All of you know him. So, again, this time I don't introduce you, Dr. Kiran. Over to you directly for your precious words.
Yeah. So, with your permissions, Neha, this is the first time I think we'll break the protocol. And I would request our guests of honor to speak first because it's a AMOGS program. And both of them are revered teachers, Dr. Murlidhar Pai, and of course, who's a good friend of us, and Krishnendu, if Krishnendu is joining later. So I would request Neha, you please introduce Dr. Murlidhar Pai to the audience and let us take his remarks, and then I will.
Yes.
Thank you
In
so much.
fact, thank you so much for allowing me to do this. It's an honor to introduce Dr. Murlidhar Pai sir. Definitely, as you said, a revered teacher, I would say teacher of teachers. And he, sir, is the professor and head of OBGYN department of KMC Manipal since 2016 to 21. And he is the founder and current chairman of Karnataka College of Obstetrician and Gynecologist. Sir has 682 guest lectures, 201 publications, 13 best teacher and teaching material, and 4 best research awards. And he's the author of Holland and Bruce 4th edition, OBGYN PMFU 1st edition, both elsewhere, and 36 years of teaching experience, 30 years of experience as examiner. So we are really privileged to have you, sir. Definitely. Over to you for your precious words of guidance. Thank you.
Good evening, everyone. Respected Kiran Koti sir, and Dr. Sneha, Dr. Monica, Dr. Swati. It's always a pleasure to participate in any which way, whether it's a guest of honor or whether it's a speaker or a panelist or whatever it is. It's always a pleasure, and especially when Dr. Sneha invites, it's impossible to refuse, and I somehow make it a point to attend all her webinars, because conducting or organizing webinar is not at all easy. You have to coordinate with so many people, and today it is the 60th one. That is only in the hat of the emergency medicine coordinator. Earlier, I don't know. She must have be having the count, but I think it's more than 200 or 300 webinars or she has conducted over last so many years. And usually what happens is people are very active when they are contesting for some post, and after that somehow the activities come down. But Sneha is an exception for that. Irrespective of winning or losing the elections, that is just a part of the life. But her main reason is furthering the academics and serving the people. That's exactly why I appreciate attending her webinars. I'm not saying that others are not doing with sincerity. They are also doing with sincerity. But I see a special trait in Dr. Sneha. That is, the life should go on. That kind of a trait. I like it very much. And I sincerely hope and wish that this time you definitely wear the hat of Vice President of Foxy, which you very richly deserve. And today's topic, again, of course, is a very important topic: obstetric emergencies or medical emergencies in obstetrics. So, we all are fraught with the emergencies. Always others make fun of us, physicians, surgeons, saying that obstetricians do not know much, anything more than conducting deliveries, or even they consider us as wicket keepers. We just catch the babies and God delivers. But we all should equip ourselves with this kind of a knowledge. That's why these webinars are very, very important, because we may not have really learned that during our training. So this kind of webinars are really making us equip ourselves with these kind of situations to handle these kind of situations. So I wish the webinar very best, and I wish Dr. Sneha you very best, and all the best to you.
Thank you so much, sir. Thank you so much. That means a lot for me. And thank you so much once again for accepting our invitation. So, as you rightly said, yes, definitely. As a breast committee chairperson, I have done 450 activities throughout my tenure, 3 years, and that was COVID. So 150 physical on-site activities and 300, almost 450 activities. And of course, as Medical Disorders Committee Chairperson, around 100 activities. So thank you so much for appreciating that. We move ahead with the precious words from Dr. Kiran Kurtakoti, our AMOGS president. So
Thank
definitely,
you.
yeah.
Thank you, Snehas. Thank you for that. Thank you for inviting me, and thank you for introducing us to fantastic teachers all over the nation. I mean, I hope your next webinar, I think you should now bring international faculties. So that was my that would be a dream come true for everyone. So definitely yes. And I would request all of you, please vote for all the elections. Elections is started. Maximum people should vote so that our representations should be at the center. So that is the only intention. Whom you vote, I'm not going to say, but maximum voting should be there from all the 4 states at the center of India. So thank you so much. Thank you, Sneha. And as Dr. Pai rightly said, it's a very important topic, medical emergencies in pregnancy, because of the advanced age, more and more cases of diabetes, hypertension, obesity, these are on the rise, and we really need to tackle these and address these issues very seriously. As against the time when we used to be postgraduates 25 years back, when these issues were not that common. So, really look forward to the webinar, and thank you so much, and my best wishes to you and everyone. And my regards also to Dr. Parag, Dr. Anupam, Swati ji, and Dr. Monica also. Monica, after 15 days, it's your turn. So best
Yes,
wishes to you also. And with this, I would request you to get on with the program. Thank you so much.
Yes. Thank you so much, Dr. Kiran. We now move ahead with the words of wisdom.
ma'am.
Parag,
Yeah, Parag sir.
Hi,
but
Sneha.
I
Thank you.
already introduced you.
No,
Please.
don't
Yeah,
don't don't waste time in that. Thank you, Sneha. I bring greetings from AMOGS, and it's indeed a pleasure to connect to friends from Jharkhand, the state which I visited about a month ago, and had 2 wonderful programs at Jamshedpur and Ranchi. It's indeed a pleasure to share virtual dias with Dr. Murlidhar Pai and, of course, my very dear friend Dr. Kiran Kurtakoti. Sneha, on behalf of AMOGS, we actually should thank you for crossing the boundaries and taking AMOGS to a different level, because connecting to other states and talking about obstetric emergencies is so important, especially in states where maternal mortality is still high. My best wishes for the program, and of course, the elections have started, and our very best wishes to you for a successful outcome this time. Thank you.
thank you. Thank you so much, Parag. Thank you so much once again. Thank you, Murlidhar Pai sir, Kiran, and of course, the respected faculties. I think both of them are not reachable, so I think we have their blessings later when they join. Over to you, Monica, for the
Yes,
academics.
ma'am.
Yes.
Thank you, ma'am. And I now declare that the inauguration is over. Thank you, Kiran sir, Pai sir, and Parag sir for the gracious presence today. I would like to invite Dr. Sneha Bhuyar, madam, as the moderator for the panel discussion. And I would like to introduce our panelists for today. The panel discussion is on the medical disorders in pregnancy. Our first panelist, Dr. Banita Sahai, madam, is the director of Sahai Clinic and Research Center, the ex-president of the Jamshedpur OBGYN Society, and she's a faculty in MGM Medical College. We welcome you, ma'am. Our next panelist is Dr. Swati Singh, madam. She's a senior consultant and laparoscopic surgeon and a clinical director at Srijan Super Speciality Hospital at Jamshedpur. She has been the vice president of the Jamshedpur OBGYN Society currently, and the executive member of the Safe Motherhood Committee, FOXY, and the Society of Fetal Medicine, FOXY Dhira, and HPV Master Trainer. She's been a faculty at various conferences and presented papers. We welcome you, ma'am. Our next panelist for today, Dr. Sarita Kumari, madam, is the chief consultant at Tata Main Hospital and assistant professor at Manipal Tata Medical College. She's also worked for malaria research project in pregnancy. We welcome you, ma'am. Dr. Anupam Singh, madam, is a consultant at Ramgarh, Jharkhand. She's a trainer and assessor of Manyata from the Jharkhand district. She's also the recipient of the Jagran Nari Samman Award of 2016 and the recipient of IME Dr. Kanak Goyal Award in 21. We welcome you, ma'am. Our next panelist is Dr. Vandita, madam. She's a senior consultant at the District Hospital, Jharkhand. She's active member of various societies, and she's a master trainer of stillbirth attendant, of comprehensive abortion care, of FOXO, and Minilab at various centers. We welcome you, ma'am. Our next panelist is Dr. Radhika Kumari, madam. She's an associate specialist gynecologist at Tata Main Hospital, Jamshedpur. We welcome you, ma'am. Our next panelist, Dr. Preeti Roy, madam, is the Joint Secretary of the Ranchi OBGYN Society in 21 to 23. She's also a consultant at the Sai Astha Hospital and Research Center. She is also a consultant at the Manipal Hospital, Ranchi. We welcome you, ma'am. Ma'am, over to you to please conduct the further
So
panel
thank you so
discussion.
much, Monica, for a very important help. And I think Nivedita will be joining soon. So,
Excuse me, ma'am.
yes, please go
Actually,
ahead.
ma'am, I think Dr. Pooja's name was left in introduction part.
Okay, Monica, just check. Doctor?
Yes, ma'am. Dr.
Pooja
Pooja
Lal.
Lal, ma'am.
Yes. Let me. Pooja Lal. In my list, she is there, definitely.
Ma'am, she is there, but I think her CV slide is missing, ma'am.
Okay, never
Yes,
mind.
ma'am.
So welcome, Dr. Sangeeta, welcome Dr. Swati Singhal, Dr. Vinod Agrawal, Dr. Sarita Kumari, Banita Sahai, Dr. Pooja Lal, Dr. Radhika, Dr. Vandita, Dr. Rashmi, Dr. Shikha, and Dr. Preeti Roy. We have a jumbo panel here. So friends, as Dr. Muralidhar Pai has rightly said that, medical emergencies are on a rise, and we obstetricians should be well versed with with the management. We have to, because we have to manage these patients then and there only. So till the time we call for help and your your anesthetists and your intensivist friends reach to your place or to your hospital, I think it may be too late. So at least the primary aid or first aid or the primary management where you actually require the basics of cardiopulmonary resuscitation and all these things, these we all have to be very well versed. So Dr. Swati, I would like to ask you, are the medical emergencies during pregnancy are really on a rise, and what can be the
Yeah,
probability?
madam. First of all, good evening to all, and thank you, madam, for this wonderful opportunity. You have very rightly said, medical emergencies during pregnancy are on steep rise, and because of the change in demography of that obstetric cases and obstetric practice, because of mothers are elderly mothers, their change in lifestyle, dietary habit, increased obesity, associated comorbid medical and surgical condition, ART pregnancies, operative intervention, and of course, placental problems are also associated. So, predicting this, you have to predict and prevent and manage these patients accordingly. These are giving you success in managing this type of cases.
Correct. So you have very rightly said that, it's not only the magnitude of the medical emergencies that is on rise. In fact, it is the spectrum which has also broadened, So, and of course, you have, nailed it that yes, the changing demography of the obstetric population, the women are becoming career minded. The advanced stage of marriage, also even planning the pregnancies, has become now secondary, and the work stress, the lack of physical exercise, this sedentary lifestyle, and also the junk food, because they are not happy, they're staying away from home, etc. Smoking, alcohol, all these things lead to obesity and the resultant infertility. That itself, lead her to ART procedures, which predisposes her to the predisposes her to be the high-risk pregnant woman with multifetal pregnancies, etc. And yes, because of the age per se, she does has the medical and surgical comorbidities, increased operative interventions, and of course, that leading to placental complications. So now we go ahead with the case scenarios for discussion, and here we are with the first case. Do we have the first panelist, Dr. Vinod Agrawal here?
I don't think he has not joined.
Okay. May I know how many panelists have joined here? Can you please rename, Saiti, can you please name our panelist? Yeah, so first case scenario we take up, we have this 36-year-old woman who conceives after IUI. Her husband stays in Dubai and she stays in a village. So because it's a prestige pregnancy, she comes to you for routine antenatal checkup up to 24 weeks. But then she finds that everything is normal and then she's lost to follow. Suddenly at 34 weeks, she reports to a primary healthcare with complaints of pedal edema and upper abdominal pain. So when the medical officer examines her, her blood pressure is very high, 176 by 116 millimeter of mercury, and she's got proteinuria, whatever is available in there. So the rest of the investigations are not done. But the blood pressure is very high, so the medical officer just gives a tablet nifedipine retard and warns her that she should get admitted at the higher centers. Unfortunately, for 2 days she doesn't get admitted, and then after 2 days she goes to the higher center, that is sub-district hospital. So with tablet nifedipine retard, the blood pressure has come down to 168 by 110, that is 110. And here again they add tablet labetalol and start her on magnesium sulfate. Now here they have the facilities for cesarean section and anesthetists. So they go for cesarean section. 1.8 kg female baby is delivered. Patient's blood pressure, in spite of all this, remains between 140 to 180 systolic and 100 to 110 millimeter of mercury diastolic. So the patient was on nifedipine, labetalol, and Maxal. So suddenly, after 10 hours, this patient actually starts getting severe cough, breathlessness, restlessness. Her blood pressure is 220 by 118. Oxygen saturation is 70%, and her chest is full of wheeze and adventitious sounds, no clear breath sound. What is your differential diagnosis and how do you manage it? Yes.
Can I take this?
Yeah, please. Dr. Anupam, is anybody there? Anybody else? Dr. Anupam? Yeah.
Ma'am, may I take this question?
Yes, please put on your video because I can't see you all because the name is also not, you have not named yourself. Please go ahead. Yes.
Ma'am, it is a case of pulmonary edema due to severe preeclampsia.
Perfect. So any other differential you would like to keep for her?
Yes, ma'am. It can be a case of acute respiratory distress syndrome or any case of infection or any other complications of infection may lead to this type of cardiac problems. If patient is having previously any cardiac disease.
No, so we know that she doesn't have. That's the reason we have not mentioned. We will come to it. Other case we have for cardiac disease also, but for this she is totally previously otherwise having absolutely no medical history, significant history. Okay, so here it's only severe preeclampsia leading to pulmonary edema. So how do you manage this patient? Please go ahead.
Ma'am, these type of patients should be managed in critical care unit, and intensive treatment is required in these cases.
But here this happened in your hospital. No. Wait, just let me in. So at the initial part, you have to manage, right?
Yes. So antihypertensive should be given. Then
you have to manage it because this has happened in your hospital, right?
Yes, ma'am.
Can you hear me,
madam? Yes, madam. Can I take?
Hello?
It's an acute emergency condition.
Dr. Swati?
Yeah, it's an acute emergency condition. You have to shout for help and maintain the airway breathing circulation. And most important is you have to give diuretics to reduce that preload to heart. And it's a good, at least 40 milligram IV start. And proper position, oxygenation by mask. And you have to control that high blood pressure. And that most probably the first line of drug is IV labetalol. And it should be, and then with supportive treatment, you have to give all the, send all the investigation, and this patient should be treated in intensive care unit with multidisciplinary team. But basic, you have to start immediately.
Hello.
Yeah.
Hello. Please go ahead. Please go ahead.
You have to, and simultaneously you have to rule out coexisting cardiac disease also. So if facilities are available, you can go for that ECG, echo, bedside, X-ray, and send all the investigation, including cardiac enzymes, and prefer, you have to control the BP so that, and continue the diuretics, and this patient need nebulization also in form of aminophylline, and supportive measures should be continued with intensive monitoring of this type of patient.
Hello. Can you hear?
Yeah, madam. Madam, please unmute yourself.
Yeah, can you hear me? I think this is the network issue from my side, or all of you can hear me well?
No, we can hear you, madam.
Yeah, meanwhile, I think, getting the, can you hear me properly?
Yes, madam.
Okay, so go ahead, no problem. So, see, basically what Dr. Swati has discussed, that yes, you have to, because this is an acute catastrophe, you have to manage the patient as ABC of, of any catastrophe. So airway, breathing, and circulation, that you have to take care of. But yes, if she is breathing well, you have to give oxygenation, and of course, propped up position, IV Lasix 40 milligram, as she has rightly said. But this patient, for this patient, help was called, oxygen was started, she was given propped up position, 40 milligram of IV bolus Lasix was given. But during this 1 minute or so, the pulse disappeared, BP was not recordable, and oxygen saturation dropped down to 55%. Then on AMBO assisted, respiration, she was being shifted to ICU along with the anesthetist. But on the way only, she, developed cardiac arrest. So how do you manage her now? Cardiorespiratory arrest. Yes.
She's already in
I think we have to
ICU
take it up fast. We have, all of you, please go ahead fast. Yeah.
She's already in ICU setup. She need mechanical ventilation, but by the time CPR should be started.
Yes. So how do you give CPR? That is what I'm asking you.
Actually, it's very important to give CPR by both of your hands, left hand below, right hand above, in the middle of chest, and you have to give 32 ratio. That and the pressure should be like that. That chest should compress at least 5 centimeter below, and then revert back on each mechanical ventilation.
Yes, on each
so that. And simultaneously you have to give supportive measurement, and she need intubation and mechanical ventilation further.
Yes. Right. So this patient was actually managed by, do we have Dr. Sarita Kumari? Sarita Kumari? Is Dr. Banita Sahai joined? No? Okay, let us go ahead. So actually, see, now that with the help of anesthetist and intensivist, you have managed this patient well, and she, after around 1 hour, she starts on spontaneous respiration. Blood pressure also is is 100/60. Okay, so she's improved later. But what went wrong, and where? Was it preventable? That is what we have to analyze. So I want all the panelists to start right from the beginning. Do we have Dr. Banita Sahai? No? Banita Sahai म्हणून एक call कर बरं तिकडे. Dr. Swati has already been talking. Dr. Sarita Kumari, we don't have. Dr. Pooja, do we have Dr. Pooja? Can you please all open up your video? Put on your video, please. Anupam Singh, I can
Yes,
see
ma'am. I'm
labeled.
here.
Yes,
Yes, ma'am.
and Swati Singh. My dear, can you please label yourself? Can
Yes,
you
ma'am.
please
I'm
write
already
your
labeled.
name?
My video is on.
No, not yours. The other panelist, I'm telling. Sahiti, can you please label the one with our friend from the one with the specs? I can see. Can you please name yourself? Rashmi Singh, is it? What is her name?
Madam, this patient, starting from the history, she's elderly patient, ART pregnancy, non-compliant patient, not going through regular antenatal checkup, and suddenly at 34 weeks, she came
she's going through a regular antenatal checkup. That is what I said, that because it was a precious pregnancy, she was coming for regular antenatal checkup up to 24 weeks, where she was informed that everything is right.
Yeah, madam, it is very important in first trimester. You just predict, you do that gestosis scoring and predict whether she's a high risk for hypertension and all these things.
Right.
So first trimester scanning and marker is very important regarding uterine artery pulsatility index and split ratio. And here we can add low dose aspirin and high dose of calcium in this patient because she is a high risk for hypertensive disorder. And again, when she came to PSC, she was not managed well with antihypertensive.
Before that, I would say that when you have scored her, labeled her as high risk, you have to tell that you are a high risk woman. So you have to for regular ANC checkup. Every visit.
You should go for regular ANC checkup, and these patients should be labeled high risk and should be managed at higher center. If they can afford. If they can afford, they can manage that higher center.
Right. And now,
excuse me, ma'am, can I add something?
Please.
So,
what is your name? What is your name?
Hello, ma'am. I'm Dr. Shikha Anand. I'm a fetal medicine consultant.
Perfect. You are the right.
I'm from Ranchi.
Yes.
So, ma'am, nowadays at 11 to 13 week, we are doing NT-scan and we are screening for Down syndrome, which is the prevalence is about 1 in 700. And we are not screening for preeclampsia, whose prevalence in India is about 10%. So with every NT-scan, the screening for preeclampsia should be done. And it should not be restricted with the with measuring the uterine artery PI only. So there is a FMF software by which we can predict the risk of preeclampsia by doing a scan alone. Hello, am I audible?
Yes. Go ahead.
Hello. So it says to combine the patient demographic profile and mean arterial pressure and mean uterine artery pressure. Hello.
Yeah, Shikha, please go ahead. We can hear you. Thank you.
So when you combine the mean arterial pressure, mean uterine artery pressure, and the patient demographic profile in which we put the weight and height of the patient, you can easily get a prediction of preeclampsia before 37 week and before 34 week by putting these in the FMF software, which is freely available. And if you are making the NT report on the FMF software, then it automatically, along with the Down syndrome risk, it automatically generate the risk for preeclampsia as well as risk for IUGR. And those patients who have a high risk, that is more than 1 in 100, should be started with 150 mg of aspirin at bedtime.
Perfect. So that is about screening. Now, when the patient, basically the obstetrician should also tell her that she is high risk and she should come for regular antenatal checkup. Your threshold of starting antihypertensive should be lowered to 140/90 because these are the guidelines nowadays. Not that previously how it was 150/100. So the moment you diagnose that she is hypertensive, that is 140/90. You have to start her on antihypertensives. You have to keep her on continuous surveillance. Now you tell me when the patient, okay, so all this is not done by her. It's a mistake on a part. But then when she reports to the primary healthcare center, how should you manage this patient with such a high blood pressure? I request all of you to please keep your video on. Then only the discussion will be fruitful. Please keep, Dr. Swati, please put on your video. Yes. So do we have Dr. Sarika? I can see there are 9 panelists. Dr. Sarita Kumar is not there. Dr. Pooja, do we have Dr. Pooja?
Yes, ma'am, I'm here.
Yeah, so go ahead. When she reports to the primary healthcare center at 176/116, what is the antihypertensive of choice?
Ma'am, we'll start tablet labetalol, which is the drug of choice.
176/116.
Ma'am, then we will give IV labetalol if it is.
But then at PHC, can you give IV labetalol?
No, we cannot give over there.
Then what is the drug of choice? See, at PHC also you have a drug which you can give at PHC. Okay, capsule nifedipine, the orange color capsule, 10 milligram. If you give it orally with water, definitely that controls the severe hypertension. So for severe hypertension, mainly 2 drugs, the IV labetalol and capsule nifedipine 10 milligram. Okay.
So in that setting only, we have to consult the patient and tell the patient how was her situation is, and fetal monitoring is also very important along with management of BP. So she needs to be informed and transfer the patient to higher centers.
Higher centers. So the sub-district hospital is not the place to undertake surgery or cesarean section for this patient. This patient has to be referred to the tertiary care center, that is some medical college or some institution where you have the multidisciplinary team, right? So that was again a mistake. And then even after they operate, this patient needs to be shifted to the obstetric SDU or ICU and not in the ward, right? So that is how at all the stages. And when you take the patient for surgery, you go for preload, right? So for these patients, like patients of preeclampsia, you have to restrict your fluids, right? So the pre should not be given or given with very caution,
because it will worsen the pulmonary edema if it is already there, settled in.
And when you deliver the baby, no to mithergine, and of course you have to prefer giving carbetocin. And if no carbetocin, then you can give concentrated oxytocin, right? Right. Yeah. Okay. So that should be all, I think, from this case. Now we go ahead with the second case. Do we have Dr. Banita? I think we can take up third case. Let us wait for her if she joins. Otherwise, we'll go ahead with that case. Now, do we have Dr. Radhika here? Dr. Radhika, please unmute yourself.
Yes,
Please unmute. I can hear.
Yes, ma'am, I'm here.
Yes. So, Dr. Radhika, here you have this. You have two devices connected, so you need to log out from the mobile, I think. Dr. Radhika, because of that, the echo. Yeah. Dr. Radhika, can you hear me?
Yes, ma'am.
Okay. So here you have unregistered primary gravida, married for 2 years, and she comes to you with 9 months amenorrhea. Now she's got pain in abdomen, discharge per vaginum, and mild fever, cough, and breathlessness. She has tachycardia since last 3 to 4 days and no pedal edema. So she was having. Yeah, because of the 2 devices, there is echoing. I can see Dr. Nivedita. Hi, Nivedita.
Good evening. I'm so sorry I joined late. Actually, I was taking a morning.
No worries. You are there as an expert with us. I think the experts have not joined, so you be here. So no pedal edema. So she was having no pedal edema, and she was having mild pains. She developed spontaneous rupture of membranes. So now, because she was she has developed rupture of membranes. She was augmented with oxytocin, but unfortunately, she did not progress, but landed up into fetal distress. Now, this anesthetist examined her, and he found that she's got a diastolic murmur. Okay, so with great precaution, they have taken up for cesarean section. But the moment he delivered the baby, and immediately within few minutes, she started becoming severely breathless, restless. So, what is your diagnosis, Dr. Radhika, and how do you manage this, and how whether it could have been prevented? That's the question once again. Yeah.
Ma'am, most likely this is a case of a heart disease, likely rheumatic heart disease, because she's having a diastolic murmur.
Yes.
And as the patient was not booked with us, so we could not have known her past history. So presently we did a cesarean section. After that, the patient should have been managed with anesthesia and gynecologist combined in the ICU setup.
Yeah, but then the patient is on operation table only. She started feeling breathless here only. When the
Yes, ma'am.
anesthesia, yeah.
Yes. Ma'am,
So how to manage? Yes, go ahead, please.
Ma'am, after the cesarean section, with the anesthetic support only, you have likely shift this patient to the CCU care.
Yeah.
And there we can do proper examination and management. We have to keep her in a propped up position, oxygen monitoring. Then I would like to go for a ECG. And after the ECG, as my hospital supports it, get a 2D echo done also for the patient. And then we can give diuretic support.
Okay, so you have managed this patient, but now you tell me whether this was a high risk heart disease or a low risk heart disease.
This is a high risk.
Yes, a medium risk or high.
Medium risk or high risk heart disease.
Yes. And for this patient, what are the aggravating factors?
Ma'am, likely she had developed some infection as she was having mild fever with cough and breathlessness. So that aggravated her heart disease.
Right. So, do we have Dr. Vandita? Dr. Vandita? No?
Vandita is actually in the labor room. So she just messaged me saying that, ma'am, I'm stuck in a case, so I'll be late.
Okay, no problem. So anybody can take up. How do you classify the heart disease according to NYHA and according to etiology? This will be a revision for all of you. Please, Dr. Anupam.
Ma'am, it's the NYHA classification is the functional grading of heart disease, where grade 1 is symptomatic, asymptomatic.
Yes, go ahead.
With routine activity. Grade 2 is symptomatic with routine activity. Grade 3 is symptomatic with less than routine activity, and grade 4 is symptomatic at rest.
Correct. And how
according to etiology, the commonest is the rheumatic heart disease, and other than that, we have the congenital heart disease, which could be cyanotic or acyanotic. Then we have cardiomyopathy, and there could be other causes of heart disease as well, which could be due to thyrotoxicosis, hypertensive, or syphilitic.
Right. So we now see somebody said she was not registered, she was not diagnosed. But then let me tell you that, you have the pregnancy itself, the physiological changes itself mimic the heart disease. Like as you know, you have the patient feeling easy fatigability, restlessness, breathlessness. Sometimes she gets palpitations also. When you hear that, apex is little laterally, you hear the some sort of murmur also, but it is usually systolic. So how do you differentiate it from the organic heart disease?
Ma'am, there are the subtle differentiations. In pregnancy, we do have breathlessness, palpitations, but there are subtle differences. Wherein in heart disease, we generally have dyspnea which aggravates on lie down, that is orthopnea. Then we have a history of nocturnal cough. There could be hemoptysis as well. The murmur is the differentiating factor. In pregnancy, we generally have a systolic soft flow murmur. Whereas in rheumatic heart disease, we generally have the diastolic murmurs.
Right. Okay, so when you diagnose such patients, what is your team should be? Whether you should manage it in an individual hospital or you should have a team? And what should be your team consist of? Whom should you be included in that?
It should be managed by teamwork, madam, multidisciplinary approach. And that team should include gynecologist, cardiologist, anesthetist, neonatologist, and intensive care unit expert also. And this patient should be work up very nicely and kept in high risk patient and should deliver at high center.
Okay. So suppose this, such kinds of patients, suppose they come to you for a preconceptional counseling, then what do you do? What do you do in that preconceptional counseling? There are certain categories of heart disease where there's a very high maternal mortality. So such patients should never conceive.
Not have. Like Esserman syndrome, pulmonary hypertension, these patients should not get. And if she's in grade 1 or grade 2, she should consult cardiologist. Proper workup should be done, and in pregnancy, proper checkup and proper monitoring and higher center delivery. All these should be planned beforehand, and patient should be counseled very rightly. And she should know about the risk, maternal and fetal risk also, and regarding the chances of anomaly in baby also, cardiac heart disease in baby also.
Right.
If she's having
and
congenital heart disease.
High cost that also involved, and the emotional stress. Not only the patient, but the entire family is going to go through, right? Okay, so so suppose, Dr.
Can I just add a point here? Sorry to interrupt. One important thing is that there are certain heart diseases, especially some of the rheumatic heart diseases, are correctable. I mean, I'm not saying they're reversible, but they're correctable. And if detected in the preconceptional area, in the preconceptional time, we should advise them to get the surgery done. It's really helpful. And a lot of surgeries, because post pregnancy, it is very expensive, as Dr. Sneha has rightfully said, but there are a lot of centers, and Jamshedpur has such centers where surgeries are done free of cost.
Dr. Banita, actually, she called, she said she's not able to join. So I was talking to her. So somebody can please help her. So, Dr. Rashmi, do we have Dr. Rashmi here? We should this woman, now the high risk woman whom we tell, that you should not conceive, pregnancy for you will be, a high mortality. So that's the reason we should not conceive. So suppose such woman, she conceives as early pregnancy, she comes to you. Would you advise her MTP or would you allow her to continue? Yes. We cannot hear you, my dear. I think you have joined without audio. You have joined without audio. We cannot hear you, or your device volume is very low. Yes, your device volume is very low. Did you join without audio? So, can somebody help her, please? Okay, so anybody can take up this question by the time. Yes, Dr. Pooja. Dr.
Pooja. There are some conditions which are high risk in which pregnancy is contraindicated, like in Eisenmenger syndrome, primary pulmonary hypertension, in Marfan syndrome with dilated aortic.
That we have said that pregnancy is not indicated, pregnancy is contraindicated. But suppose such patient conceives, what is your way of management? That is what is the question.
If she comes in first trimester, we can advise NTP for those patients.
Yes, that is what we want to know. That it's not that now, unfortunately, she has conceived, so let me see whether she, goes through uneventfully. Yes. No, it's a very, very fatal.
No.
Associated with very high mortality. In such condition, definitely you have to take the cardiologist and physician into in the loop, and you take a documentation that yes, this lady has got this disease and this is the status and she is advised against pregnancy, and then you write it down everything, you give take an informed written consent saying that we have got the evaluation done from a cardiologist and this is his opinion. So as an obstetrician, we would not be able to manage this pregnancy. It's better that she undergoes termination of pregnancy, and likewise, you have to go ahead with the termination of pregnancy. Suppose she comes to you, I mean, as she will say, doctor, how much time do I have to take the decision? Do you allow her to progress further or how?
No, ma'am. We'll tell her that in first trimester only she has to decide, and we have to terminate the pregnancy.
Yes, because
she cannot
second
go
trimester
beyond that.
pregnancy is as good as labor, right? So that is, she's she is exposed to that stress of labor, and that is why a strict no for second trimester pregnancy. It should be as early as possible. That is before 8 weeks of pregnancy. That is what is the message. Okay. So Dr.
Yes.
Shikha, this is a question for you. How frequently? I think you are a fetal medicine specialist, right? But then this is a question for you. How frequently should the patient come to you for antenatal care, and any special advice to be given?
So for any cardiac, yes, ma'am. So for any cardiac patient, we know there are two high risk period. So one at the first trimester and another at 28 to 30. So in the beginning, the care should be at 6 weeks. As early as the pregnancy should be diagnosed, this patient has to come. It should be a coordination between the cardiologist as well as with the obstetrician. And every 2 weekly up to 30 week, and then weekly the monitoring should be done. And most importantly, if it is category, if NYHA classification is on the higher side, like on the 3rd and 4th, at 28 week, then the patient should get an inpatient monitoring. It should be admitted. Anytime if patient goes in NYHA 3 and 4, it required a inpatient management.
Yeah, immediate hospitalization. So that takes you to any special precaution you advise to these patients?
Okay, yes. So hygiene is very important, because any type of fever, infection will put her at a risk of heart failure. So she should have a oral and
also
as well as yes. And for and benzathine penicillin, yes, can be given 3 weekly to prevent the recurrence of rheumatic fever. And she should take all her drug as prescribed by the cardiologist. Like most often we see that these patients are put on beta blocker as well as digitalis. Then we should use. And if the patient is having a prosthetic valve replacement, then she will be on warfarin. So the switching over of warfarin to heparin is important in the first trimester. And then after the first after 13 weeks, she is again put back. Hello?
Yes, go ahead.
Am I audible?
Yes.
After 13 weeks, we again put her on her oral anticoagulant, and we look fetus for the if she has an exposure of warfarin in the first trimester, we look to fetus for the warfarin embryopathy, like choanal polyhydramnios, as very common in those patients. So fetus monitoring is also required in this. And again, at the end, we again switch the patient from warfarin to low molecular weight heparin or unfractionated heparin before planning the delivery.
Right. So here actually, comes the role of, whether you should advise her to, allow her to come in labor directly, or you would like to hospitalize the children. How do you decide that?
So if the patient is on anticoagulant, and we have to switch the anticoagulant at 36 weeks, I said like an NYHA 1 and 2 can go up to 30 weeks, and 3 and 4, irrespective of POG, they should be get admitted. And after 30 weeks, this patient should be managed at the hospital setting.
Right. So, during labor, what special precautions? Suppose, do you allow her to go into spontaneous labor, or you induce her, or you take her up for cesarean section, Dr. Anupam? Dr. Anupam? Oh, she was here just now?
Yeah.
Yes, Dr. Anupam, I can see her. Anupam?
So can I take it?
Yeah, Anupam is muted.
Yeah. Go ahead. Yes,
Hello?
anybody can take up. Yes, I have said yes.
Okay, so institutional delivery is very important in this, but there is no role of induction of labor per se as a heart disease case. It should be done if other obstetrical indication is there. And the mode of delivery, the preferable mode of delivery should be vaginal, but in some cases we require to do an elective cesarean section that depend upon the patient's heart status. So if the patient is in NYHA 4, then going for a vaginal delivery would not be possible, and anesthesia and the patient will require a ventilatory support. In that case, we will go for cesarean section.
Right. So, what are the poor prognostic factors, Dr. Swati? Dr. Swati? Dr. Swati, please unmute. Welcome, Dr. Banita. I can see you. Banita. Yes, we will have your case after this. Yes, you have to unmute.
Yeah, madam, high risk category, grade 3, grade 4 are the poor prognosticated factor. Any infection beforehand is the poor prognostic factor. And when the high risk, I have any other associated condition like ischemic disease, arrhythmias, and when her heart condition is not very good, ejection fraction is less, then these are the poor prognostic indicator.
Right. So we go to Dr. Banita's.
And disease like.
So basically, you have to keep it in mind that, high risk heart diseases, that is NYHA grade 3 and 4, especially those who are, in which cases, maternal mortality is very high, they should not be allowed to become pregnant. And if at all by mistake they become pregnant, early pregnancy termination before 8 weeks. And if, they are having heart disease before pregnancy, optimization of their condition before they conceive, right? And the benzathine prophylaxis. Frequent visits with the obstetrician and cardiologist, and they have to coordinate with each other. Absolutely no indication for induction unless it's a obstetric indication. Okay. And then, of course, you have talked about the criteria for admission. So, Dr. Banita, we have this patient for you. Dr. Banita, please unmute now. Now you unmute yourself. So we have this grand multipara admitted to emergency ward at 11 p.m. That's a case of obstructed labor. Okay, she's got tachycardia, blood pressure is normal, but mother is exhausted because of the prolonged obstructed labor. Like her is meconium said. So she was given antibiotics, fluid resuscitation, and she was taken up for cesarean section. 4 kg severely distressed baby was delivered, and that was managed by neonatologist. There was a slight extension of this, uterine incision, which was repaired well. And then after shifting, there was no significant blood loss. After shifting the patient to ward around about an hour after the shifting to ward, the patient suddenly became, confused, drowsy, disturbed respiration, and the blood pressure was only 80 millimeter of mercury. So what is your diagnosis, Dr. Banita? How do you come to the diagnosis, and how do you manage this patient? Yes, Dr. Banita? Do we have Dr. Banita on board? Yes, you unmute. Unmute, my dear. I can see you.
Oh.
Unmute. What is your diagnosis?
In this patient, we will think about the bladder or ureter also. We will think whether they are being obstructed or what. And even if those are normal, then we will see for the urinary output is there or not. We'll think about it. So the chances are there she's going in shock, maybe the pulmonary embolism or maybe the any cardiac shocks or neurogenic shocks she must be having, or she might be having any diabetic ketoacidosis if she has come in labor and we have gone for cesarean. So we will think about even the diabetic ketoacidosis.
Okay, so your patient is in shock, that you agree, right? Your patient is in shock, but she has neither bled intraoperative, not bleeding postoperative. So what kind of shock is it?
It can be due to the pulmonary embolism.
Yeah, so this is called as non-hemorrhagic shock, right? So, Dr. Pooja, I would like to ask you what bedside investigations can tell you. See, your patient is in shock, but she is already having IV fluids. So whether you should give large volumes of fluids or not, that you have to see. But then you have to check whether she needs fluids or no, whether it is a hypovolemic shock or whether it is a cardiogenic shock. That you have to make sure. So what bedside investigations can tell you? Yes, Dr. Pooja.
So, ma'am, for this case, we will. Ma'am, can you hear me?
Yes, I can hear.
Hello.
Yes, please go
ahead.
Ma'am,
we'll do one ABG. We will do one ABG.
But bedside
we'll look for
immediately. See, you have to manage this.
Can I say something here? Can I say something here?
Can I take this?
Can we do it for the clotting factor or the...
Madam, can I take this?
Yes, Swati.
Please.
Yeah. There are 4 catching points in this history, in this case scenario.
One thing
she's
is drowsy and the baby
is multipara of large baby, and she's exhausted, dehydrated, and there is no signs of hemorrhagic shock. So she is a case of non-hemorrhagic shock, and there are so many things you have to differentiate her, whether it is cardiogenic, neurogenic, or diabetic hypoglycemic shock or diabetic ketoacidosis, because she is multi and large baby, and she's confused and she's in non-hemorrhagic shock. Though first of all, we want to see how is its blood sugar, whether she's in hypoglycemic shock or in hyperglycemic shock.
Okay, so we did her bedside investigation. Her hemoglobin was 10.8, her sugar is 550, her urine dipstick shows ketones 3+ and sugar 4+. Now you tell me what is your diagnosis.
She is in diabetic ketoacidosis.
Okay, just tell me in short, how do you manage this patient? By the time
actually in diabetic ketoacidosis, fluid replacement is very important, because there is hyperglycemia that cause osmotic diuresis and cause hypovolemia. So you have to replace fluid very nicely along with insulin, and within first 24 hours, 70% of your fluid replacement should be given. And there is usually these patients develop
Okay, so let me tell you
acidosis. So you have to correct that.
Yes, Dr. Swati, I will just, see, all of you are now having your anesthetist and diabetologist physician intensivist friends coming to your rescue. Definitely, yes. You have to just understand and manage the initial situation. Now here the question is not managing, because the physician or the diabetologist friend will manage everything. As an obstetrician, coming to the diagnosis, having high index of suspicion, doing the bedside test is important for management of this case. Let me ask you the question, whether this could have been prevented.
Yeah, madam, definitely this could have been prevented. Every patient, because India is a diabetic hub, every patient should have universal screening for diabetes in first visit only, and then repeated in every trimester. That is dipsy, blood sugar 2 hours after 75 gram glucose, and managed according to the breeding.
Yes, single step 75 gram OGCT, that is post glucose 2 hours. Okay, the blood sugar levels. Now we go to the last. I think all of you have already discussed, right? So do we have somebody who is not talked? Should we take up the case or we should close? I think it's already 6:15. Yes, Nivedita?
I think you
Dr.
can take
is not there. One case last. Okay, quickly. So 29-year-old paraban delivered 5 days back. She comes to you with dyspnea, fatigue since 2 days now. Because the symptoms were significant, she came for evaluation. She was dyspneic and hypoxic. Her saturation was 88% only. Now, so immediately when she comes to the casualty, oxygen was started. So with oxygen, her saturation now comes to 95%. She's afebrile, pulse is 90, BP 156 by 88, respiratory 20 per minute. Her chest, there are no adventitious sounds. Heart rate is regular, but there is a atrial gallop. There's no pedal edema, no calf tenderness. So what investigations you would like to do, and what is this condition? How do you manage it? Post-delivery, postpartum.
Post-delivery, postpartum, more likely going towards the cardiac problem.
Yes.
Maybe cardiomyopathy, postpartum cardiomyopathy.
Perfect. These are all the investigations we have already discussed. This is a treatment. PPCM per se does not have a very definite treatment because the etiology itself is not identified. It is only symptomatic management. So early diagnosis and supportive management, right? Though people are saying that yes, bromocriptine has a role, and yes, prophylactic diuretics have a role, it is still experimental. And there are lots and lots of problems, autoimmune response to fetal cells in maternal circulation, so many, etiological hypotheses that there is no exact. Only thing is keeping your patient healthy, having, keeping very high index of suspicion, catching it very early, giving the supportive care problem, just sail through, manage her so that, it is a spontaneous security. PPCM can be very catastrophic, and it can be life-threatening. So all of us have to keep these conditions very, very in the mind, because we have to keep a very high index of suspicion. Because once it becomes too late, then it becomes very difficult to manage. And the moment you suspect this condition, get her evaluated, get her echo done that time. But preferably, if you have a hypertensive woman, though Tamil Nadu says that they have, routine echo for every pregnancy, at least for a hypertensive anemic patient, get 2D echo done at least in second or third trimester. I think that is the way you can definitely diagnose the dilatation cardiomyopathy. So with this, I conclude our panel. I thank Dr. Nivedita and Monica especially for, doing all the exercise for me. I thank all the societies of Jharkhand for being with me, supporting me, and, looking forward to work with all of you. I can see so many bright members here from Jharkhand. I would be very happy to work with all of you, dear friends. Just make a humble appeal to vote for me in maximum numbers, and please do share my vote appeal to your maximum members. May not be in the Jharkhand, but all over India, I would request, and help me in getting there. Thank you so much.
All the best, madam. You will be winning this.
And
the best, ma'am.
Thank you, madam. And our best wishes for your tenure as a vice president.
Thank you so much. Thank you. Yes. So Nivedita.
So, okay. It's indeed a pleasure to be associated with AMOGS, Jharkhand Societies of Ranchi, and Jamshedpur, and association with AMOGS. So I would start by thanking the present AMOGS, Dr. Kiran Kurtukoti, the Secretary General, Dr. Vipin Pandit, the immediate past President, Dr. Rajendra Singh Pardesi, the Chair ICOG, Dr. Parag, who is also the National Coordinator AMOGS, and a very special thanks to Dr. Sneha, who has taken out time from her very busy schedule, because I know how busy she is with the campaign. She has been traveling she's been traveling yesterday, just got back today. She's doing one webinar with us. She's got another webinar at 7 p.m.
Three today. I finished 2 now.
So she's really very busy, yet she has time to go through each webinar with so many topics very meticulously. So I really thank her, and all of us here are wishing you all the very best, and we are all voting. Believe me, we are all voting, and हमारे सबके ग्रुप में यही चल रहा है कि डॉक्टर स्नेहा भुइयार को देना ही देना है, उसके बाद दूसरा वाइस प्रेसिडेंट चूज कीजिए. But that has to be, there is compulsory. Jharkhand societies have to vote totally for Dr. Sneha. From West Zone, Dr. Sneha's name has to be there as the first thing. Then
I request all of you personally.
Yeah, no, I very strongly believe, I very strongly believe, so it's not just a vote of thanks, it's a vote appeal also, because I strongly believe that Foxy needs people who can make an improvement, not just a change, but make an improvement. And this is being probably recorded and is going to be sent somewhere, I don't know. But, and especially for people like us from Jharkhand and 3-tier cities, we need somebody who knows us, who knows our problems, and who knows how to improve our situation in Foxy. Because all gynecologists are facing a lot of problems, and there has to be someone standing with us. So I believe Dr. Sneha is that person. And I sincerely, I sincerely pray and wish that she gets elected. And I want you all to do your bit for that. Please, it's a humble request from my side. बड़ी बहन, बड़ी दीदी, बड़ी मौसी, जो भी समझो, बट कर दो यार, इतना इज्जत करके कर दो. Then going on to the official vote of thanks, I would like to thank our chief guests, Dr. Suchitra Pandit and Kiran Kurtkoti, who again came over to bless the webinar. Then Dr. Murlidhar Pai, who was there as a guest of honor. Then, of course, our fantastic panelists, Dr. Banita ma'am, Dr. Swati Singhal, Dr. Sarita, I didn't see Sarita, but Dr. Pooja, Radhika, then Anupam, Preeti, Rashmi, Vandita, Chitra. Oh, you're there?
Most of them are there. I think only
yes. Lastly, madam, I am requesting and want your commitment. After winning this election, you are going to visit Jharkhand and especially Jamshedpur.
100%. 100%. That
and especially Jamshedpur.
100%.
This is our young brigade. This is our young brigade, Dr. Sneha. We purposely got our young brigade today because we believe that our young brigade, all the seniors have interacted, but we needed our young brigade to interact with you, to get them to know you, to meet you, and to realize that that it's their turn now, and they have, the young ones need to come forward and vote now.
Yes.
So all of you, and I thank my co-convener, Dr. Monica. She really took on the lead because I said I was busy taking a Manyata class. We have these Manyata classes. I was busy with the Manyata class, and which got over at 5:30. I would like to thank Shield, especially Sahiti, who I batter constantly. Every time I said, change karo, wo karo. So Sahiti takes a great...
yeah, she's really very sincere and perfect.
And she was on leave till 31st, and then 30th, and then suddenly from yesterday, like she's been active. So thank you, Sahiti, and thank you, Shield. And overall, I thank the audience who've come together and who are listening to us. And I hope that topics like these, medical emergencies, labor emergencies, are helpful to you all, because you are all the budding aspirant gynecologists and obstetricians of tomorrow. And if you're aware, what we are aware of, only then we can treat. As I say, what the mind does not know, the eyes do not see. So webinars like this are the ones which are going to open your mind to complications that can occur, unheard, unseen, but arising from somewhere. So if you are aware, if you know what could be the outcomes, you'll be better able to manage it and will prevent maternal mortality and optimize women's health. Thank you, everyone.
Thank you so much. Thank you so much. Just help me, all of you, get maximum votes. Thank you so much. Thank you, dear. Thank you. Thank you.
Thank you.
We're all voting and we're getting all our colleagues to vote.
Yes, thank you, my dear.
Bye.
Swati, Sarita, Radhika.
I forgot to think. आज हमको join करना है. Thank you, Nivedita, for adding me.
Banita ma'am, ensure voting in the first 3 days.
हाँ,
Please tell your society
इसीलिए
members.
because first 3 days में ही voting होता है, बाद में तो voting होती नहीं है.
So please ensure voting. Thank you.
होती नहीं है, पता नहीं क्यों block हो जाता है.
नहीं, thank you. Thank you. Okay.
Thank you. Okay, Nivedita.